Hello and welcome. I'm Autumn Lafretta, the Education Manager here at the Foundation. Thank you for joining our Answers from the Expert webinar. We are very excited to have you here with us. Before I introduce our panelists, I'd like to go over a few housekeeping items. We are here for Q&A, so please have your questions ready and put them in the Q&A tool in Zoom. We will be answering questions that were submitted ahead of time and questions that you are submitting live throughout the webinar. We would like to thank our individual donors and our funding partners for making programs like this possible. We will be recording this webinar and it will be available on the Foundation's YouTube channel within a couple of days. And upon conclusion of the webinar, we would like you to complete the survey that pops up. It's very helpful for us to know what we're doing right or what we can improve on. So please take time to complete the survey. So now I would like to provide some information on the speakers we're going to have with us today. We have Dr. Eric Moe, whose specialty is hematology and oncology. He was born in Oregon, raised in Iowa, where he cultivated his initial interest in science and medicine. He completed his undergraduate and medical school training at the University of Iowa before heading to Stanford University to complete an internal medicine residency and hematology oncology fellowship. We also will be joined by Dr. Amrita Goyal. She majored in evolutionary biology at Harvard, attended Harvard Medical School. She completed a combined residency in internal medicine and dermatology at the University of Minnesota. This was followed by a dermatopathology fellowship in the Harvard Combined Dermatology Fellowship. Please welcome our clinicians today. Welcome, Dr. Goyal. Welcome, Dr. Moe.
Thank you so much for having us.
Hi, Adam. Glad to be here. Thanks.
Thanks for taking the time out of your busy schedule to be here. So we're going to get started with our questions, but before we do, I'd like to give a reminder that Dr. Goyal and Dr. Moe are answering these questions based on the experiences that they've had with their patients. Please do not consider these second opinions. They're just sharing their knowledge with you. So with that, let's go ahead and start our first question. How should skin be cared for after phototherapy treatment within the African American population? What products are best?
I can take this question. This is actually a great question, and it has an answer that's applicable to pretty much everybody, especially anybody with ongoing dermatologic conditions. Basically, what we want you to focus on is gentle skincare after your phototherapy sessions and between them. As part of phototherapy, there's always a risk of burning. You always can have some skin irritation, so I want you to focus on taking lukewarm showers. You don't have to shower every day. Use gentle soaps like Dove, sensitive skin type things. Moisturize when you get out of the shower. I do recommend a cream formulation. It's a little more moisturizing than just a lotion. Ointments are also great. Sometimes they get on your clothes and people don't like that. And that's kind of the basis of gentle skincare. And if you do sustain a burn during a phototherapy session, I would encourage you to talk to the dermatologist that's guiding your treatment and see if a low potency or mid potency topical steroid might be helpful in their opinion. But other than that, just over-the-counter products like CeraVe, Vanicream, Aquaphor, anything you can get at a general drugstore is what I would recommend.
Okay, thank you very much. Our next question. I always hear that mycosis fungoides stage 1A is a stage you can live with for a long life. What about stage 1B if the rashes are recurrent but controlled by light treatments, sunlight, and ointment? Good long-term outcomes?
In general, patients with stage 1A and 1B mycosis fungoides will live long, healthy lives. There is a small subset of patients that may undergo disease progression. It can be very difficult for us to predict who those patients are, but odds are in your favor that this will not be a life-limiting illness.
Thank you. That was always good to hear. So someone put in live after talking about second opinions is, should we consider getting second opinions? So I don't know if either of you, who wants to tackle this one first?
Yeah, I can offer a perspective. Thank you for the question. I'm a strong believer that second opinions are very useful and informative. I think it goes along with the theme that in diseases like cutaneous lymphomas, which are uncommon, advocating for oneself is so key. This is something that often goes unrecognized for a long time. And even when recognized, because they are rare diseases, they can be very hard to understand what the perfect or correct treatment is in any given situation. If you meet your healthcare providers and believe that their plan of care makes sense and you agree with it, then that's the most important thing, and you could comfortably proceed with that plan of care. But if there's any part of you that says either I want to hear another thought process or I would just like to get more information, I think you should advocate for yourself and not be shy about requesting that second opinion. And I would hope that any provider that you meet that you raise this question about would be willing to entertain that and actually encourage it, because it's not about following the directions of a specific person. It's about understanding what's best for the patient, no matter who they get that information from and how many opinions it takes.
Thank you. That was a great answer. I think that's one thing that we sometimes forget in the American healthcare system is you can always go to another doctor. You don't have to, if you're not comfortable with it or you want another opinion, we have that right. All right, let's go with our next question. I was diagnosed with MF 7 years ago. In the last 4 months, I've had many plaques in my body and tumors in my face. In the last 2 weeks, they've been growing in size and volume exponentially. Now I have many plaque clusters and 7 big tumors in my face. What can I do to get rid of them ASAP? That sounds rough.
So every case is different, but from what you're describing, I think seeing your doctor, either your dermatologist or if you have an oncologist already, seeing them as soon as possible for evaluation would be the best thing to do.
Okay, thank you. What are your overall thoughts on clinical trials? I think this is something that both of you could have some insight on.
Yeah, I could start. We, in general, are such strong advocates for considering clinical trials. And I think one of the challenges is across the different types of cancers and disorders we treat in medicine, patients with cutaneous lymphoma are often left behind because there are fewer trials for patients with rarer conditions. And I think that really is one area we really need to improve on as a community. And so if you're able to seek out opportunities to participate in clinical trials or understand where they might be offered, I think it's really important to consider whether that would be logistically feasible for you to at least get more information about. We know that we have a large toolbox of therapies, whether skin-directed or systemic oral pills or IV, but we know that there's such an unmet need even despite that presence of existing treatments for us to improve everyone's long-term success rates who live with this condition.
Dr. Goyal, would you like to add anything?
No, that's great.
Okay, thank you. Do you know of any connection of cutaneous T-cell lymphoma and is it lymphedema? Am I pronouncing that right?
Lymphedema? Yeah.
Lymphedema, thank you.
So there are many, many causes of lymphedema, ranging from cardiovascular to renal to completely unrelated to any systemic problem. I've definitely seen patients with cutaneous lymphoma who have had problems with lymphedema. So I would encourage you to talk to your doctor to help pinpoint any other underlying reasons that you may have lymphedema. It's not a major first line symptom I think about with CTCL though. So I would make sure to investigate other causes.
Thank you. Is there any way to predict length of remission following treatment with Adcetris?
I can take this question. So for those in the audience who are not aware, Adcetris is one of the infusional IV targeted therapy agents that we have at our disposal to treat patients with cutaneous lymphoma, most commonly people with mycosis fungoides, Sézary syndrome, and another condition called anaplastic large cell lymphoma. Like many drugs that are explored, they're meticulously studied to understand their side effect profile, how well they work across a broad range of patients, and we do have that data. But one thing I think is so important to highlight is, as many are aware, the world of cutaneous lymphoma is really exemplified by the word heterogeneous, where you can see such a wide range of people who have excellent responses to treatments or those who do not respond as well as we'd hoped. And so it's very hard to assign a specific number or rate of response or expected percentage of response for any single person. Depends on what medical conditions a patient might have, the characteristics of the lymphoma that they're facing. But the hope is that we can thread a needle and use a treatment and find it to be effective, and if so, continue it for as long as possible with acceptable tolerance. Some patients I treat with Adcetris can have many months or even years of control of their lymphoma, but other patients run into either side effects sooner than that, or we find that the lymphoma is unfortunately not responding as we'd hoped sooner than that. So I think what's really important here is to make a shared decision with your healthcare provider about whether it's something that is worth trying after examining the risk and benefit, and then following closely to understand whether things are responding as expected or whether there are any unforeseen complications arising.
All right, thank you. That was a really, really thorough answer. We appreciate that. The best use, when, how to apply, frequency, etc. of triamcinolone and clobetasol.
So when you get a prescription for a topical steroid, your physician or advanced practice provider should have given you instructions on how to apply it. In general, topical steroids are once to twice a day to the affected areas, but make sure to check in with your prescriber.
All right, thank you. Can phototherapy completely eradicate the CTCL skin lesions? Roughly how long will the skin lesions reappear, recur after phototherapy?
This is a great question. And as the same theme that's come up multiple times, every patient with CTCL is different. So it is possible for patients to get excellent clearance of their skin lesions on phototherapy, but the duration for which you will stay clear can vary widely from patient to patient. I've seen patients who were treated in the 80s and stayed clear until they saw me now and needed retreatment with phototherapy. And I've seen patients that never get completely clear, and we have to consider other therapies to go with their phototherapy. So it's very hard to predict.
It's what I've had some clinicians say: if you've seen one patient with CTCL, you've seen one patient with CTCL, because everybody is unique. All right, we'll go on. The next is, does FMF always progress? Is there a progression rate? Is early stage stable disease possible?
So FMF, for those people who are not familiar, is a variant of mycosis fungoides, folliculotropic mycosis fungoides. So this is a histologic subset of disease that is considered in general to be more aggressive, but that doesn't mean that every patient that has this histology progresses. It's very hard to put a rate on progression because it depends on what stage you were diagnosed and things like that. There are definitely patients who have an indolent course and have a very good prognosis, and there are a subset of patients who do progress. So I would probably discuss with your dermatologist or oncologist who has more knowledge of your clinical scenario and your pathology to get a better sense.
All right, thank you. I feel like I just keep saying thank you, thank you, thank you, but we are very thankful that you are here today answering our questions. I have experienced a variety of symptoms, mostly related to my skin. For example, I have the Sézary red rash, itchiness, various types of peeling and flaking, hypersensitivity of skin, and aching hands and feet. Most of these symptoms come and go. How am I supposed to figure out if I'm getting better or not?
I can take this question. First of all, thank you for sharing your story, and it's very clear that you're going through a lot and experiencing a lot of symptoms, and it really highlights how a diagnosis of what we think, and many people out in the community, if they hear about a skin lymphoma, think about something as simple as a skin rash. We know it can be much more than that, and Sézary syndrome can cause a variety of symptoms, as you've described. And the question is a good one because it can really be honestly hard to understand in the short term whether we're making progress with a certain treatment. And I think this is because not only are you trying to work through the symptoms that brought you to medical attention in the first place and prompted the need for treatment, we also recognize that treatments themselves have side effects that can compound the symptoms you're already facing. So what we try to do is, number one, lean on the guidance of your healthcare professionals, your oncologist and your dermatologist, to help you understand what objective markers, that is data they can measure from blood tests, from examining your skin, from doing scans when relevant, to understand whether we're seeing things move in the right direction on paper, and then combining that with your testimonial as a patient, knowing that's not just what we see on paper, but your experience. And sometimes it's easier to try to, especially if you're getting the reassurance that we have the opportunity to wait and take it step by step, day by day, week by week. Slightly zoom out, give the treatment a little bit of time to see if it's working, and try to measure progress in a bigger picture sense. Sometimes the first 2 days after treatment can feel very different than 2 weeks later or 2 months later. And sometimes the treatments we use, we know, do not act immediately. A lot of the clinical trials that investigate the drugs we've used more recently oftentimes help us understand that treatment responses, even when drugs end up working, can take several weeks or even a couple of months. So a combination of patience and safe guidance from your team, I think, will help lead you to the right track.
All right, thank you. We have next on how much radiation is too much radiation. I'm approaching my 15th round of targeted radiation in 8 years.
This is a great question. And again, it's very complicated. There are many kinds of radiation that can be given. And what matters is going to be the dosage, the type of radiation, the specific locations. And the only way to get a good, hard and fast answer to that is to talk to the radiation oncologist, who would have to review your records and discuss your case with you specifically. There are certainly limits, but they would be best able to evaluate your specific case.
Thank you. I was diagnosed with MF stage 1B in April of 22. It was well controlled with NBUVB, Acitretin. I'll get the correct pronunciation. Yet I keep hearing reoccurrences to be expected. Why is that? What causes patches to return? As I navigate reducing my treatment over time, how concerned should I be about reoccurrence? Does recurrence lead to progression? That last question, we hear that a lot, and how to determine what is going to progress and what isn't.
So mycosis fungoides is generally considered an incurable condition. And at the early stages, our major goal is to manage your symptoms. And therapies are going to be either skin-directed or oral to try to manage the skin rashes and any itching and discomfort that may be associated with them. And we are unable to get complete clearance typically, and patients often do experience recurrences. It's very difficult to determine, to assess how long you may stay clear with any given therapy. But what's going to be really important is just keeping your regular visits, because if you do develop new patches and plaques while you're on therapy, there are numerous other lines of therapy that can be considered. The risk of recurrence doesn't really correlate directly with the risk of progression, as far as the literature is able to show us. So our goal with early stage disease that does not appear to be progressing is to keep you comfortable.
I wanted to add to Dr. Goyal's point that with something that is oftentimes measured on a timeline of many years, where we understand this to be a chronic process, it really is so important to distinguish between the presence or recurrence of the actual lymphoma that we can see versus the significantly symptomatic presence of what we can see. And that is to say that some people, even after a certain treatment, may notice that there are minor areas of recurrent skin problems, rashes that we can visualize. But if they're not bothersome, then it doesn't always necessitate the urgent need to start a new treatment that can carry with it side effects and toxicities. We know we're really trying to make this a marathon instead of a sprint, understand that we're trying to maximize quality of life of the patients we care for, while also keeping them safe from disease progressing to significantly symptomatic stages. So that's such an individualized conversation, but just wanted to make clear that we really try to parse out just the presence of the disease versus how it's actually affecting you as a person.
Thank you. That was really, really good to hear. Your thoughts on carmustine cream ointment is a new one for me.
Yeah, it can be very effective. I have not touched it myself, but to my understanding, it can stain clothing. So that is my one caveat. But if your dermatologist feels that is the most appropriate therapy for you at the time, I would definitely try it.
Thank you. In your opinion, can an individual with stage 1B who has noticed about 30 new small patches this past year keep practicing active surveillance? Surveillance. See, I told you that I was going to get stuck on a word today. 74-year-old who has had MF for 3 decades.
anytime you have a change in your disease status, so you develop a new morphology of the lesions or suddenly develop a new number of them or develop a new symptom, I would want you to talk to your doctor and see if there's any other evaluation that they would want to do to make sure that there's no additional symptoms that they need to be concerned about or additional progression. But if it turns out that it's just skin limited, it may be possible that active surveillance could be an appropriate treatment, but it's going to be an individualized decision based on evaluation in person.
Okay. Newly diagnosed. Anything I should be avoiding as far as food, sun exposure, activities, certain skin creams?
This comes kind of back to that same gentle skincare regimen. I want you to avoid anything really harsh or astringent. In general, when we recommend gentle skincare, we say to avoid things that are heavily fragranced because people are more likely to react to them. In terms of food avoidance, I advocate that you eat a healthy, balanced diet. There's no hard evidence to suggest that any particular dietary modifications would make a significant difference. Some people feel that sun-exposed areas may clear a little better than non-sun exposed areas. However, I don't advocate just going out and sitting in the sun because that comes with an additional risk of skin cancer. I would talk to your doctor about the possibility of phototherapy in that event.
Due to onset of neuropathy from Adcetris, besides increasing treatment interval from 3 to 4 weeks, what else can I expect? What have you seen in your patients?
Yes, so I can speak to this. Again, this is a question about the drug Adcetris, which we saw in a prior question. It's an IV therapy that is a directed antibody, so trying to target a protein called CD30 on lymphoma cells to kill them. One of the primary side effects we can see from Adcetris, as this question asker is writing, is the emergence of peripheral neuropathy. What we know about it is that it is common with extended use, and the more doses that a patient receives, the higher the risk of developing neuropathy. We also know that if we back off before the neuropathy progresses to more significant symptoms, such as affecting dexterity or the ability to write or button close, then we know in the vast majority of cases it does dissipate over time after stopping the drug, though it can take sometimes several months. So there are strategies to try to help make what is a very effective drug against lymphoma more tolerable for the long term, because some people find themselves finding it working for months on end, but they can't tolerate it because of the emergence of neuropathy. So in this patient's case, it seems like their healthcare provider has extended the interval between treatments, which is one strategy that can be used to try to space out treatments. The hope is that this will reduce the rate of neuropathy. The challenge is the drug was studied primarily on a fixed schedule. And so it's about having a very individualized conversation with your oncologist about how do we strike that balance between the idea of trying to space out treatments long enough or reduce the dose to help reduce the risk of neuropathy, but not doing so to the point where we start to lose an understanding about how closely we're matching how it was given when it was initially investigated, because the further we stray from that, the less concrete of an understanding we might have about the expectation of how long it'll work or how well it will work. So this is a very nuanced discussion to have with your doctor, but the hope would be that in your situation that this might help continue to control your disease while improving symptoms that you might have of peripheral neuropathy.
Right, thank you so much. It was a really good answer. Does successful topical treatment for patches plaques mean that they clear, go away? I've been treating patches for 6 months and they have not cleared or reduced in size. Is a new treatment plan warranted? What would you recommend for a patient that's experiencing this?
So this can be a tricky question because when you have patches and plaques, even if they're treated successfully, you can actually end up with post-inflammatory hyperpigmentation, which leaves like a shadow of pigmentation in the area that the patch or plaque was. So you may still have areas that look different to your normal skin, but they may not have active disease. So I would want you to show those areas to your dermatologist and ask if they think that there has been clearance or if there's just residual hyperpigmentation. If the areas are not bothersome to you, then you may be able to just continue as you are. If they continue to be itchy and bothersome, then I would have you discuss that with the dermatologist and see if a different topical treatment might get you better symptomatic relief.
In your opinions, is it safe to use melatonin for sleep? There are some studies that indicate it promotes CD4 T cell growth.
I'm not personally aware of strong connections between concern for impact on lymphoma and the use of melatonin. I think that in this case, because it's when used according to typical indications, I think it's reasonable to consider. However, because there are other sleep aids that are available, if you truly feel uncomfortable using it out of concern that it might be affecting the behavior of lymphoma, then certainly reasonable to look at those alternative sleep aids as well.
Thank you. First-time diagnosis of mycosis fungoides. What would your advice be?
So my first piece of advice is that I want you to find a dermatologist that you get along with, that you like, because you're going to have a long relationship with them. You're going to need annual full body skin exams from now until forever. So that would be my first piece of advice. And that person can help you assemble the rest of your care team. Because if at some point you need an oncologist or a radiation oncologist, your dermatologist will be able to help you do that.
I'd also add that I recommend you find your community, and that may be here through the CLF. Kind of alludes to a comment I made earlier where just caring for patients in practice with cutaneous lymphomas, I've just come to recognize sometimes how it can feel a little bit isolating because it's an uncommon condition with uncommon treatments, and it's chronic, as Dr. Goyal mentioned, where it's a lifelong process for many people. So finding support in your community, finding good, reliable information, it's really crucial, because if you are newly diagnosed and you jump onto Google, there's a lot of information. And as we all know, especially for conditions that are uncommon and for expertise, where expertise is less prominent, you can find a lot of misinformation out there. So really connect yourself with trusted sources. You can ask for leads from your dermatologist or hematologist. But I think the Cutaneous Lymphoma Foundation is obviously a wonderful place and a hub to center around as you move forward.
We appreciate you saying that about the foundation. We like to be helpful and be here for the community. T cells with increased CD4, CD8 ratio detected. Are you able to explain this a little bit more?
So this is a difficult question to answer without more context, because it would matter whether this is in histology or flow cytometry, what the context of the specimen was. So without more information, I would definitely talk to the doctor who ordered the test and ask them for some more information.
Okay, thank you. Thoughts on tacrolimus for MF patches versus triamcinolone? We have a couple more questions on triamcinolone coming up, just to warn you.
So triamcinolone is a medium potency topical steroid. It's probably one of the longest studied medications for topical use for mycosis fungoides and can be very effective. However, it is a topical steroid, which is associated with a variety of side effects when used long-term, including thinning of the skin, formation of stretch marks and things like that. You can get easier bruising over time. So some patients do find that to be limiting. Tacrolimus is a non-steroid anti-inflammatory that some people have had some improvement of their CTCL patches and plaques with. I would say that the data are not as well studied and not as clear, but it's definitely a non-steroid option that you could consider. It is generally, both of them are considered very safe medications.
Okay. Could a tingling nerve sensation around in your patches be at all associated with CTCL MF?
So itching, we definitely hear about. So tingling nerve sensation, not super commonly, but I don't know why that couldn't be a similar manifestation to itching.
Okay, thank you. I have mycosis fungoides most likely. When the rash appears, I treat it with application of triamcinolone cream. After 2 weeks of treatment, the rash disappears. Is this treatment in fact effective, or would the rash disappear on its own?
That's a great question. So the triamcinolone is often very effective in helping specific patches and plaques of the mycosis fungoides to thin or completely clear. In general, the patches and plaques don't just go away on their own. But because we're just treating symptomatically, if you wanted to pick a patch and treat it and pick another patch and not treat it, you could see what happens.
That is an interesting approach to it. I like it.
That would be okay.
Right. When doing phototherapy, should the whole body be treated or just those areas affected? Presently, the affected area is the back and torso and not the face and scalp.
In general, we treat the affected areas. Typically, we do some shielding of the face and the groin when we're doing phototherapy, unless those areas are specifically being treated. So you would treat the affected areas to the best of your ability.
All right. We always have good questions on phototherapy. I have PCMZL. When would I need systemic treatment? Mine is multifocal, diagnosed in 2020.
So primary cutaneous marginal zone lymphoma has a generally excellent prognosis, was actually in some cases reclassified as a lymphoproliferative disorder as opposed to a lymphoma. In general, the majority of patients with primary cutaneous disease will not progress and may never need systemic treatment. However, local relapse is kind of the rule after treatment rather than the exception. So you may need localized therapy in the future. But Dr. Mu, do you have any?
Yeah, I totally agree with you, Dr. Goyal. Oftentimes we expect to be able to manage primary cutaneous marginal zone lymphoma with mostly either observation or local therapies. Sometimes either in the case of widespread skin progression, which can occur where you have multiple different skin lesions that are hard to spot treat with, say, injections or radiation to multiple areas, or in the uncommon case where people do progress in other places outside the skin, such as lymph nodes, we can consider systemic therapies. And there are a host of systemic therapies that we find to be very effective. And kind of like knobs on a dial, we have a whole range of therapeutics that sometimes can keep us short of the classically thought of intensive IV therapies that us hematologists and oncologists give in chemotherapy, and give things that are more tailored or more mild, like immunotherapies or antibody therapies. So again, a discussion to have with your team, but know that the toolbox is large, and in general, we're very optimistic about the prognosis and outcome for patients diagnosed with marginal zone lymphoma.
All right, thank you both. Have you had success with chlorambucil tablets? My dermatologist is suggesting it. I'm on 40 milligrams of isotretinoin and use clobetasol. Both have helped, but I keep getting new lesions.
I have personally not prescribed oral chlorambucil. Dr. Mu?
Yeah, so chlorambucil is an oral chemotherapy. I think the important thing to clarify here is understanding what the diagnosis is that you're facing. We use this drug in the world of lymphomas, but really depends on the context and the diagnosis. So hard to say, but I think the general idea that you're raising here, which is if you have skin lesions that are growing despite the plan that you're on, I think it's worth considering alternative treatments, whether that's chlorambucil, other oral therapies, other chemotherapies. That, again, I think we would need a little bit more information, so worth talking to your team about.
Okay, thank you. Before we go to the next question, we had an attendee ask a question. They started off with their progress has been a roller coaster. You did not mention what treatment you're on. So if you could add that into the Q&A, I can update the question, because as it is now, we're not sure what you're taking, so it'll be hard for the doctors to answer. All right, we're ready for the next question. I've had MF for 28 to 30 years. I was in stage 1A for approximately 27 years, but the disease has recently gone into stage 1B with patches appearing on limbs, neck, and armpits. I'm 74 years old and wondering if I should start treating since the cancer is incurable and will come back.
So again, stage 1A and 1B are both early stage disease, but as we said before, anytime you have a change in your disease, increasing number of lesions, a change in what they look like, we do want you to get reevaluated and see if any additional blood work, any additional studies would be necessary. In the event that your doctor says that, yeah, it's just new patches on your skin, then the treatment decision would be whether or not they're bothering you.
All right, thank you. I have relatively minor mycosis fungoides. I'm 30 and have been diagnosed for 10 plus years. I apply clobetasol occasionally. For someone living a normal life with MF, should I be on the lookout for anything special, more aggressive frequent screenings, or should I watch out for other things?
Yeah, so patients with mycosis fungoides are with early stage non-progressive disease. You will likely not have any limitation of your life due to your mycosis fungoides. So you're at risk for the whole host of normal things people are on their skin. So we recommend annual full body skin exams. And there is some evidence that patients with mycosis fungoides might have a slightly increased risk of other kinds of cancers. So we do recommend that you keep up with your primary care appointments and maintain your just general health screenings and your age and gender specific cancer screenings. So if you're due for a pap smear, if you're due for a colonoscopy, just keep on top of those things.
All right. I would like to know about the impact of CTCL on pregnancy and the fetus.
Yeah, I can take this question. There's not a lot known about the concurrence of CTCL in pregnancy, and I guess I can derive a couple of different angles I'm getting from this question, whether one, that there's a connection between the two, whether someone who is pregnant has a different experience of cutaneous lymphoma and how it behaves. So we don't really know the answer to any of those questions. It's the combination of a rare disease and an occurrence that only happens in a fraction of patients diagnosed with CTCL. With that said, there is ongoing effort to try to understand better this scenario. And I was mentioning to the team before we started this call that here at the University of Iowa, we're trying to propose a research project to search out patients who have had a diagnosis of cutaneous lymphoma and been pregnant and understand, is there anything about their experience with regard to their pregnancy, with regard to the behavior of the cutaneous lymphoma that is different than people who are not pregnant. So we're trying to learn. I think the most important practical takeaway right now is if there's a need to think about treatment of CTCL when someone is pregnant, we often need to really be considered about the impact of treatments and their side effects on the health of the fetus. And so that's something that really requires sometimes not only care from a dermatologist and hematologist oncologist, but also our OB colleagues as well.
Yeah, for our female patients of reproductive age or anyone who is able to become pregnant, if you are considering a pregnancy, trying to become pregnant or pregnant, definitely check in with anyone who is prescribing any medications for you, because we want to make sure that what we're giving you is safe in the context of a pregnancy as well. Topical steroids are generally safe, but if you're on something like a retinoid, like Acitretin, that would be unsafe in a pregnancy.
Right. And we do have on the foundation's website a chart that is with reproductive health in relation to the different treatments on whether it is safe or not safe to take it. So you can find that on our foundation's website. All right, our next question. How does CTCL in early stages affect response to COVID? What steps should be taken to lower risk?
So I can start with this. Again, a lot is dependent on the degree of the lymphoma and how it impacts someone's health, both by the presence of how much skin disease or other disease is there, but also whether a patient is on treatment. When someone is receiving treatment, as you can imagine, many anti-lymphoma or anti-cancer therapies can impact someone's immune system and make them more prone to infections. We know even outside of treatment, people with diagnoses of lymphoma in general, there's something about a diagnosis of lymphoma that probably signals that that person's immune system is slightly knocked down a peg or two compared to someone without a diagnosis of lymphoma. So we do know that people with diagnosis of lymphoma can have a higher risk of contracting COVID-19 and are more at risk for severe disease. But you can imagine this really is different between someone who has a few scattered patches and plaques and is not needing treatment, and someone who has many tumor lesions or a lot of disease who's on active chemotherapy.
So basically, we would encourage you to take all of the normal precautions, including getting vaccinated against COVID-19. The vaccine is safe for the vast majority of patients, but if you have specific questions, talk to your doctor. That's what we're all here for. Masking when appropriate, keeping your hands clean and washed, avoiding crowds if you're worried. Just those general same avoiding the flu, avoiding all those other respiratory infections precautions.
All right, thank you. My progress has been a roller coaster, starting on 150 milligrams of Adcetris, then after developing kidney issues, reduced to 100 milligram and rashes coming back, then increased up to 138. The dose is working, but I have developed neuropathy, and then now the time between treatments has been extended to 4 weeks, and I'm currently taking gabapentin to control symptoms. Anything else I should know or do to make the journey easier?
I can start with this question. Thank you for sharing your perspective. Clearly, there's been ups and downs, and it's been challenging to find a steady state here. What I would say is that this really highlights the challenge that we see in trying to, again, stay between the yellow lines of the road and control the lymphoma that's causing problems, but also have it done with a person having acceptable quality of life while on treatment. Sometimes it's easier said than done. In the case of Adcetris or brentuximab, as you're mentioning, this is a very common scenario that we run into where peripheral neuropathy can make it very challenging to continue with the plan as we intend to. So what I'd say is you're doing what I think is a very reasonable first step, which is talking with your team about finding ways to stay on a drug that sounds like it's working, but trying to lessen the side effect profile of it to see if it allows you to maintain and continue on the treatment. If that's not working, I encourage you to advocate for yourself and tell your doctors that you're really finding it hard to have a good quality of life while on treatment, even if it is working, and asking them about the pros and cons of other treatments. Because like we said before, there are other treatments. Some work better in certain contexts than others, but it's our obligation as your doctors to tell you what other options there are if you're telling us that it's very hard to live a good quality of life with what you're dealing with on a certain treatment. So ongoing conversation, but hopefully lessening the interval in that way will help you feel better while being able to maintain control of the lymphoma.
Okay. I haven't heard anyone mention, I think we may have talked about this once, the fluocinolone ointment for MF. I have some success with it keeping things stable. What are your experience with your patients using this ointment, if any?
Yeah, so topical steroids come in a range of strengths. So like over-the-counter hydrocortisone would be the weakest. Clobetasol would be among the strongest that we typically prescribe. Fluocinolone falls a little stronger than triamcinolone, but not as strong as clobetasol. I would just caution that as you go up in strength, the likelihood of having side effects from a topical steroid when used for long periods of time, including thinning of the skin, dilated blood vessels, easy tearing of the skin, those risks do go up. So I would try to find the lowest strength topical steroid that controls your symptoms, because that will help minimize the number of side effects you have, but it's a great treatment option.
Okay, thank you. I want to do on a time check. We do have 15 minutes left. We still have a handful of questions to get through, but if anyone that is watching live, if you have any additional questions, please make sure you get them into the chat. All right, next is I've had MF for 28 to 30 years. I was in stage 1A for approximately 27 years, but the disease has recently gone into stage 1B with, wait, didn't we just answer this one already?
We did this one.
Yeah. We did this one. So Mike, we should be at when doing a PET scan for CTCL, my first time diagnosis, what is the doctor looking for? Or I'll read it slowly, and then if you guys want to address it while Mike's doing that. When doing a PET scan for CTCL MF, first time diagnosis, what is the doctor looking for?
I can start with that one. So it's a great question. It's because we often think about cutaneous lymphomas as being skin-related diseases, and that's true. That's the focal point of how we evaluate people. But we also know that, though uncommon, depending on the extent or the characteristics of the cutaneous lymphoma, the lymphoma can sometimes involve areas outside the skin. And the main compartments we think about are internally, so commonly lymph nodes of the body or internal organs. And the other compartment we think about is the blood. And so for the blood, we can obviously look into this via blood work and blood tests. But a scan, whether a CT scan or a PET CT scan, is an effective way to understand whether there are any concerning appearing lymph nodes or areas of organs that we can see that might raise concern for additional testing or even biopsies that could be performed and considered if it's thought that the lymphoma is involving those areas. The decision to do a scan is also individualized because we understand that for people with lesser amounts of disease or thin plaques or patches, sometimes the chances of finding something internally are so low that we may be able to defer that study. But the decision is ultimately a shared one between you as the patient and your doctor team. So have a conversation about that with them.
Okay, thank you. What is a good CD4 to CD8 ratio?
So this is a relatively broad question. What I'd say is CD4 and CD8 refer to, I believe in this context, the different types of immune cells you have, specifically T cells. And because we know that lymphomas arise, in this case, cutaneous T cell lymphomas arise from T cells, sometimes we can learn about the characteristics or the presence of lymphoma if we see an abnormal balance between the number of CD4 and CD8 T cells in the body. We have a normal proportion, and when that's thrown out of balance, that can suggest there's something going on. But again, it really depends on, as Dr. Goyal mentioned in response to another question earlier on, where are we looking? Is it in a biopsy? Are we looking at the tissue of the skin for presence of lymphoma? Are we looking at the blood to see if there are abnormal excesses of one type of T cell in the blood? So more context is important here, but when you see CD4 and CD8 in the context of cutaneous T cell lymphoma, that should be a trigger that your doctors and your team are trying to ask a question, probably something related to the presence or signs of lymphoma in whatever compartment that they're examining.
All right. Can going to the light box once a week be helpful in treating CTCL? I think that's one for
Lots of
Dr.
good
Goyal.
light box questions. Yeah, so how often people get phototherapy is, again, a very individualized treatment. Oftentimes, we'll start with 2 or 3 times a week, and then once we get your disease under good control, we'll taper off. And some patients stay stable at once a week. Some people are able to go every other week. It really is person to person, and some people vary from season to season. So it's going to be kind of your body's choice in a lot of ways.
Okay, thank you. So I think this comes back to when we were talking about the compromised immune system. Why am I healthy if I have a compromised immune system from MF? So if you could expand on that a little bit.
Certainly, it's a great question. If you as a patient are hearing that you have a compromised, quote, compromised immune system, what does that mean for your health? And this is why I kind of dislike, and I apologize for using the word compromised because it's kind of an all or nothing sounding word. What I mean to say is that we do know that biologically, the presence of a lymphoma often indicates that someone's immune system may not be completely at 100% strength. But as you can imagine, even if someone's immune system isn't completely normal, there's a threshold where even if it's not normal, it may not actually manifest as someone having more often or more frequent infections. And everybody's threshold is different. So for some people, the diagnosis of mycosis fungoides does not impact their immune system in an appreciable way. Other people have issues once they start treatment, and other people get frequent infections even just by having the diagnosis itself. We probably don't completely understand the best way to measure actual immune strength. We have a few blood tests we can sometimes send to look at antibody levels, but they don't always correspond to what we see in front of us as far as your testimonial as to whether or not you're coming down with more symptoms or more frequent colds or things like that. So this is just something to keep in mind as you continue on your journey. If you're entertaining treatments or getting therapies, you might be thinking a little bit harder about how do you protect your own health if you know that overall you might have an immune system that's weaker than someone who's not going through what you're going through.
Yeah, the immune system is incredibly complicated and has so many different functions. And when we say that there is some degree of immune compromise with early stage mycosis fungoides or even advanced stage mycosis fungoides, that doesn't mean that your immune system just doesn't work. It means that there may be certain functions that are slightly depressed in some contexts and not others, so it may not manifest as you getting sick all the time. So, but in general, we just advocate hand washing all the time, avoiding people who are sick, getting your seasonal flu and COVID vaccines, and appropriate diet and exercise, because if you're healthy now, we want to keep you healthy.
Right, thank you. My wife has 2 rare diseases, MF stage 1A and CIDP that was diagnosed in 2021. Is it possible there is some relationship between the two?
I think this is really hard to answer. I think the common thread between these two conditions, in theory, could be in relationship to the immune system. As we just talked about, we know there's definitely a relationship that is not fully understood, but it's there between people's immune systems and the development of lymphomas. After all, lymphomas arise from cells of the immune system in lymphocytes. And it sounds like this CIDP condition is something that we often think of as possibly being related to immune dysfunction as well. Unfortunately, we don't have a lot of literature that helps us understand whether there's a clear connection between the two entities, and we also don't have tests that can help us prove or disprove the relationship. So I think supporting both conditions as they appropriately would be and keeping communication between both teams that treat those diseases is important, and wishing this person the best.
Thank you. Can a stage 1A CTCL MF diagnosis cause fatigue, exhaustion, or overall weaken the immune system?
So like we just talked about, there may be subtle weaknesses of the immune system, but most often patients with early stage disease do not have terrible immune compromise. We don't treat you guys like patients that are undergoing chemotherapy, that degree of immune compromise. There are a lot of reasons for fatigue, weakness, that range from just not getting enough sleep to having anemia to having a variety of other medical conditions. So if you're experiencing symptoms like that, I would encourage you to talk to your primary care doctor and to your dermatologist and oncologist and let them know you're having these symptoms. So if there's any additional workup for reversible causes of those symptoms that needs to be done, it can be done.
All right, thank you. So we had someone that wanted to share some information regarding neuropathies. They used ice pack footsies and gloves when they had chemo, and it helped. It didn't completely help, but it did help. So they wanted to share that information. So we are only going to have time for 2 more questions. So we're going to get down to our last 2 questions. In your opinion, is Acitretin the best treatment option?
Acitretin is a treatment option for mycosis fungoides. And without knowing any more information, I would say that you should consult with your doctor. And if you have reservations or concerns, definitely speak up and let that be known, and hopefully they'll be able to answer your questions.
I just piggyback on that and say it's just a broader commentary on the fact that in the world of cutaneous lymphoma, we wish we had option 1, 2, 3, 4 in that order, knowing what the best top treatments are. But the problem is most of the treatments, there are only a couple of trials that have truly compared one treatment to another head-to-head to help understand which one may be more effective. The vast majority of the treatments we have all exist in parallel, which is to say we know they all can work, they all have their different side effects, but we haven't put them against each other to know which one ranks above which. So just another reminder to please talk with your team about what is the best individualized treatment for you, because based on your other medical conditions, based on the side effects that you find most important to avoid, you might settle on a different treatment than someone sitting next to you with the same diagnosis.
Thank you. So here we have our last question. I have follicle center CTCL, multiple lesions on neck treated with radiation therapy in 2019. Several of very small presumed recurrences since treated with clobetasol or intralesional Kenalog with good response. What can I expect over the next 20 years? Will small reoccurrences continue or stop? Systemic disease?
So primary cutaneous follicle center lymphoma is one of the primary cutaneous B-cell lymphomas. It is generally indolent, can be very well controlled with localized radiation. But again, as with marginal zone, recurrence outside of the radiation field is common. If the lesions are responding well to topical steroids and intralesional steroids, that's fantastic. It's a great option to get local control without having to go for multiple radiation treatments. There is a slight risk of transformation with follicle center lymphoma. Dr. Mo, could you comment further?
Absolutely. Totally agree with you, Dr. Goyal. In general, like our prior discussions with primary cutaneous marginal zone lymphoma, we think about these cutaneous B-cell lymphomas in follicle center lymphoma as excellent prognosis, but needing to be managed over time. With that said, there is a small chance of progression, that is growth or involvement of lymphoma of internal organs or lymph nodes. but in the minority of patients, I would probably estimate on the order of 10% or less over someone's lifetime. There's also an even smaller risk of change of behavior of these typically regarded slow-growing lymphomas to more aggressive behaving lymphomas. And again, relatively uncommon. Most people will not experience this, but for both scenarios, another reason to remind people to just keep listening to their bodies. And if something unusual is happening, know that it's not always something that's happening in the skin, and to advocate for yourself to understand whether there's more testing to be done to look deeper than the skin.
All right.
I would just
Thank you
advocate that
both.
if you have a diagnosis, if you have a diagnosis of a cutaneous lymphoma, your dermatologist wants to see you even if it's perfectly controlled, because we want you to call us if something is changing.
Yes, it's we didn't talk too much about multidisciplinary team. We've alluded to it a few different times, but what we do see is that most cutaneous lymphoma patients do at some point see both a dermatologist and a hematologist oncologist, and they work very well together. So don't think that you're going to upset one over the other because you're talking to them. So we're going to wrap up here. I want to thank you both for being here, taking the time out of your busy schedule to answer all of these questions for our community. I want to ask if you have any additional parting thoughts before we sign off.
Thank you guys so much. Thank you to the Cutaneous Lymphoma Foundation for holding these sessions and for inviting me to participate.
Yes, thank you, Autumn, and the whole foundation. This really helps us learn too when we see the whole range of questions we get from our patients and caregivers and advocates. Parting words: advocate for yourself, find your community, and make sure you get all the information you need to feel comfortable with this, because it's an uncommon condition where there's a lot of variation in how people are treated. So we want everybody to be on the same page, however that means, and whatever resources you need to seek out to get that information.
Thank you so much. Thank everyone for attending the webinar. We look forward to seeing you at future programs, and please, please, please take the survey when you exit the Zoom. Thank you all, and have a wonderful rest of your evening or day, depending on where you are.